Good morning, everyone. First of all, I would like to thank the organizing committee of this convention, Dr. Edna Migo, as well as to our president, Dr. Padua, for inviting me to give this talk for this morning. So, for this morning, I will talk about the International Academy of Cytology Yokohama System for Reporting Breast Fine Needle Aspiration Biopsy Cytopathology. So, this is the outline of my talk. Firstly, I will briefly touch on the advantages and some disadvantages of fine needle aspiration biopsy. Then I will talk about what is the IAC Yokohama system, the 5-tier categories of the system with their corresponding risk of malignancy and cytologic features. I have also listed the common lesions encountered under each category. And then lastly, we'll take a look on the effect of using the system in categorizing lesions, as well as whether cytopathologists' years of experience has a big impact on the use of the system. So I have nothing to disclose. We all know that breast fine needle aspiration biopsy is one of the most common fine needle biopsies performed throughout the world, with varying applications in low and middle income countries and in countries in the developed world. It is a useful evaluation method for diagnosing palpable and ultrasound detectable non-palpable breast lesions, achieving high sensitivity and specificity for most benign and malignant breast lesions. It has a very low false negative rate and a very low false positive rate. Fine needle aspiration biopsy has been of growing significance in resource-limited settings like the Philippines, where imaging is not readily available. The advantages and disadvantages of fine needle aspiration biopsies are widely published in literature. As is listed in this table, it is a quick, inexpensive, and minimally invasive and reliable technique to use for the diagnosis of breast lesions. However, it has also its disadvantages. Fine needle aspiration biopsy is not recommended for mammographically detected calcifications, wherein in these situations, a core needle biopsy is the recommendation. Fine needle aspiration biopsy cannot detect neural or angio invasion. It is emphasized in the system that fine needle aspiration biopsy should be part of the triple assessment approach. Cytopathology cannot be practiced in a vacuum, and the cytological changes need to be interpreted in the light of the clinical findings and the imaging characteristics of the lesions. These factors form the basis of the triple test for breast cytodiagnosis. The following questions must be asked before a final clinical pathological diagnosis is rendered. First, does the clinical history suggest a malignant lesion? Second, do the imaging features suggest a malignant lesion? And third, do the cytological features suggest a malignant lesion? So when all of these three are taken together, a confident diagnosis is made in 95% of cases, and it has a positive predictive value approaching 100%. Although fine needle aspiration biopsy has the advantages mentioned previously, it has been in many centers, especially in the United States and in well-resourced tertiary centers in our country, has been replaced by core needle biopsy. It is because it has been generally regarded that core needle biopsy has a lower inadequacy rate. And in malignant cases, core needle biopsy will allow for a definitive diagnosis of invasion with more accurate grading of the carcinoma and performance of estrogen, progesterone, and HER2 receptor studies. Because of this, current practice guidelines recommend that the diagnosis of suspicious breast lesions classified radiologically as BIRADS 4 and 5 should be made using a core needle biopsies. High inadequacy rate is also one of the problems mentioned in fine needle aspiration biopsy, especially when there is an availability of rapid on-site evaluation or the ROSE. Because of the tediousness and uncompensated time in doing rapid on-site evaluation, there is decreasing interest among cytopathologists. Performing breast fine needle aspiration biopsy, making direct smears, and interpreting the material does require specific training and ongoing experience. In many institutions, radiologists have replaced interventional cytopathologists, or in our country's setting, we have few pathologists practicing fine needle aspiration biopsy techniques. The number of breast fine needle aspiration procedures has significantly dropped, reducing the experience and teaching potential for performing and interpreting fine needle aspiration biopsy smears by pathologists. The system has emphasized good technique of fine needle aspiration biopsy proceduralists, and in the making of direct smears are needed to achieve accurate diagnosis. In other centers, fine needle aspiration biopsy and core needle biopsies are regarded as complementary sampling tests, with fine needle aspiration biopsy used to assess the broad spectrum of breast lesion and as triage for those cases that would then require the more invasive and costly core needle biopsy. Consistent communications among cytopathologists and between cytopathologists and treating clinicians has at times been problematic, with inconsistent meaning for terms such as atypical and suspicious. While cytopathologists intend to convey degree of certainty for the presence or absence of a malignancy with the terms atypical and suspicious for malignancy, there is variability in their meaning between cytopathologists and clinicians. In the past, no specific definition was given for each category, and such terms have not included a defined or consistent risk of malignancy, leaving clinicians uncertain as to what subsequent management steps should be taken. There was no defined recommendations for post-cytological study follow-up and therapy as well. To address these issues, the International Academy of Cytology gathered together a group of cytopathologists expert in breast cytology who, working with clinicians expert in breast diagnostics and management, have developed the IAC Yokohama system for reporting breast fine needle aspiration biopsy cytology. The project was initiated with the first cytopathology group meeting in Yokohama at the 2016 International Congress of Cytology. And this is the recently launched published book of the system. So the IAC Yokohama system for reporting breast cytopathology has addressed issues including the indications for breast fine needle aspiration cytology, the techniques of fine needle aspiration biopsy, smear making and material handling, and making a reproducible standardized reporting system, the use of ancillary diagnostic and prognostic tests, and correlation with clinical workup algorithms. Ultimately, this will facilitate clinicians' understanding and use of FNAB cytology in breast pathology. So the system has 5 categories that can be stratified by the risk of malignancies. These are the following: insufficient or inadequate, benign, atypical, suspicious of malignancy, and malignant. And these are their corresponding risk of malignancy. As one goes up into the category, the risk of malignancy increases. Let's take the first category. First category would be your insufficient or inadequate. So this is defined as the smears are too sparsely cellular or too poorly smeared or fixed to allow a cytomorphological diagnosis. The incidence is around 0.7 to 47%, with a risk of malignancy at a rate of 2.6 to 4.8%. When no clinical or imaging information is provided to the cytopathologist by those who have performed the FNAB, such as, example, completely drained cyst, and there is no reasonable opportunity to review the case with a clinician, it is recommended that a report should be issued with a caveat that correlation with clinical and imaging findings is required because the fine needle aspiration biopsy findings may not represent the lesion. The insufficient rate in breast FNAB is influenced by, number 1, skill of the practitioner who performs the FNAB, with cytopathologists and practices utilizing rows having the lowest rate of insufficiency. Next would be the skill of those making the direct smears, where problems including crushed artifact, air drying, slow alcohol fixation, and contamination with ultrasound gel. Third would be the nature of the lesion, with high insufficient rates in lesions that are small in size, lesions that are difficult to stabilize, or serous or sclerotic lesions, and those lesions that are lowly proliferative or low cellular lesions like your lobular carcinomas, and those mammographically detected microcalcifications without a corresponding mass lesion. So in the study that we have conducted, most of our insufficient cases on follow-up are non-palpable breast lesions detected on mammography, and most are non-proliferative lesions including sclerosed fibroadenomas. The last cost would be number of fine needle aspiration passes. It is recommended that 2 or 3 passes is recommended if ROSE or rapid on-site evaluation is not utilized. So how do we define adequacy? So adequacy in breast cytology dictates that if there is a mass lesion on palpation or imaging that does not decrease in size and drain on fine needle aspiration biopsy, it is recommended that 7 tissue fragments each consisting of 20 or more epithelial cells is needed to allow assessment of the architecture and the presence or absence of myoepithelial cells. And this should be the measure of adequacy. But if there are any atypical features or necrosis, they should be reported as atypical. So what are the exceptions to the adequacy criteria? The assessment of adequacy may not require epithelial material to be present if the cytological features correlate with the clinical and imaging findings in the triple test and are sufficient to make a precise diagnosis. Such situations include pus consistent with an abscess, proteinaceous background with or without histiocytes consistent with cyst contents, when the cyst has been drained under imaging or has no residual mass to palpation after biopsy. Next will be your fat tissue fragments consistent with a lipoma or a fatty nodule, spindle cell lesions, fat necrosis, reactive lymphoid material consistent with an intramammary lymph node, or in some cases of a hyalinized fibroadenoma, which correlates with the imaging. So these are the exceptions to the rule. So one has to take note that if the triple assessment is discrepant and the fine needle aspiration biopsy material does not explain the imaging or clinical findings, then the fine needle aspiration biopsy report should contain a statement that the material may not represent the lesion, and further fine needle aspiration biopsy or usually core needle biopsy is required. When no clinical or imaging information is provided to the cytopathologist by those who have performed the fine needle aspiration biopsy, like example, a completely drained cyst, and there is no reasonable opportunity to review the case with a clinician, it is recommended that a report should be issued with a caveat that says correlation with clinical and imaging findings is required because the fine needle aspiration biopsy findings may not represent the lesion. One has to remember that the term non-diagnostic is not recommended. So what is the management for insufficient or inadequate cases? So if the insufficient is due to technical issues, the fine needle aspiration should be repeated to a maximum of 3 passes. If the insufficiency is due to a lack of sufficient cellularity to explain the clinical or imaging expected diagnosis, it should be repeated. Correlation with the clinical and imaging findings in the triple test determines further management, and this is facilitated by the use of ultrasound guidance and rapid on-site evaluation. If the imaging finding is indeterminate or suspicious, a repeat fine needle aspiration biopsy or a core needle biopsy is mandatory. If the imaging is regarded as benign or at low risk, in some practices, follow-up with clinical or imaging review may be regarded as appropriate, and this usually occurs at 3 to 6 months interval. In a setting where no imaging is available, like those in the low to middle income countries, the clinical and fine needle aspiration findings should be closely correlated, and repeat fine needle aspiration is usually recommended. The next category would be benign. A benign breast fine needle aspiration biopsy diagnosis is made in cases that have unequivocally benign cytological features, which may or may not be diagnostic of a specific benign lesion. This category makes up majority of the fine needle aspiration diagnosis, accounting for up to 77% of cases. The risk of malignancy is low at 1.4 to 2.3%. And in our study that we conducted, our rate was around 0.5%. The negative predictive value was 97.1 to 98.9%. So it is high. So what are the key cytological features to call something benign? So one will usually see predominantly large, cohesive, three-dimensional tissue fragments and or flat monolayered sheets wherein one sees evenly spaced ductal epithelial cells with myoepithelial cells resembling a bimodal pattern. There are abundant bare bipolar nuclei representing strip myoepithelial nuclei in the background. Sometimes one will see intact lobules and small terminal ductular tissue fragments. So the nuclei of terminal ductules and ductal epithelium vary in size and chromatin pattern from small and fine and in normal epithelial components to moderately large and mildly coarse in proliferative lesions, while nucleoli can vary from small to inconspicuous to a single large round nucleoli. So these are the common benign lesions that falls under the category of benign. So we have inflammatory conditions like your acute mastitis and breast abscess, your granulomatous mastitis, foreign body reactions, fat necrosis, cyst with apocrine sheets, consistent with cyst contents, fibrocystic change, lactational change, normal breast, your usual epithelial hyperplasia, fibroadenoma, intraductal papilloma, and intramammary lymph nodes. The bulk of cases that make up benign would be your fibroadenoma, fibrocystic change, and your usual epithelial hyperplasia. So this is an example of an aspirate of a breast abscess, which is due to a non-specific inflammatory process that may require microbiological studies, including culture or molecular testing to exclude tuberculosis. In this slide here, we see cell debris in the background as well as sheets of foamy histiocytes, and this is an aspirate of a breast fat necrosis. This case here shows your normal breast epithelial cells showing evenly spaced bland nuclei with interspersed myoepithelial cells at the periphery and within tissue clusters here, and a lot of naked bipolar cells in the background. This is another cluster of your benign ductal epithelial cells. Note that the evenly spaced nuclei of the epithelium, and you see abundant myoepithelial cells scattered in the background as well as at the periphery of these fragments and within the clusters. So this is diagnosed as consistent with cyst contents, and usually this is done or used when one only finds a granular proteinaceous background with no epithelium. There must be correlation with imaging and clinical findings with the cyst completely drained on FNAB. The next slide shows sheets of apocrine cells in a proteinaceous background, and this can be signed out as cyst with apocrine sheets. Here, we see your cohesive clusters of your benign ductal epithelial cells See some scattered foamy histiocytes as well as sheets of your apocrine cells, and this is consistent with your fibrocystic change. Here is another aspirate of a. The next slide shows a fibroadenoma wherein we see branching forming these antler or staghorn shaped epithelial clusters in monolayered sheets and set with a clean background with lots or abundant naked bipolar cells in the background. This is a closer magnification view wherein you see abundant myepithelial cells in the background, and we see abundant myepithelial cells at the periphery of these epithelial clusters as well as within the clusters. This is another picture of a fibroadenoma from another patient, and one would notice that the myepithelial cells or the naked bipolar cells are scattered in the background, seemingly like a white sesame seed scattered in the background. And we see our epithelial cells, which are cohesive and forming these branching patterns, diagnostic of that of a fibroadenoma. This slide here shows a fragment showing usual ductal hyperplasia, where the nuclei are moderately enlarged, but we still find a lot of our myepithelial cells interspersed within these tissue fragments as well as at the periphery. So this finding is still benign. This is another picture of a epithelial hyperplasia. So we see a huge fragment that has this slit-like spaces at the center, and we note that the cells here are forming streaming towards this along this slit-like space, and the nuclei are evenly spaced, they are bland, and with a lot of our myepithelial cells interspersed in this tissue fragment as well as in the background. So this is benign. So this is from the book of the IAC. So here we see a cohesive, irregular ductal epithelial tissue fragment, and see here the slit-like spaces. So it's not the rigid spaces that we will find in your cribriform pattern. So in hyperplasia, we see slit-like spaces with the cells streaming over the place with a lot of scattered myepithelial cells in the background. So what is the management for benign? So correlation is essential, and a benign fine needle aspiration biopsy diagnosis that correlates with the clinical and imaging findings does not require any further biopsy, and no specific recommendation is needed in the report. However, if the clinical or imaging assessment is indeterminate and not explained by the cytology, or if it is suspicious, the cytology should be reported as benign, and follow-up biopsy, usually by core needle biopsy, should be recommended. Conversely, indeterminate cases on imaging, such as an apparent fibroadenoma that may have some irregularities, when reported as benign on fine needle aspiration biopsy, do not require further workup. So for low to middle income resource settings, if the triple assessment is not congruent, I repeat, FNAB is mandatory. The next category, the third category, would be atypical. So the term atypical in breast cytology is defined as the presence of cytological features seen predominantly in benign processes, but with the addition of some features that are uncommon in benign lesions and which may be seen in malignant lesions. So the incidence is at 4 to 13%, and the risk of malignancy is around 13 to 15.7%. So it is increased compared to the benign, but still majority of these cases would be benign. So what are the cytological features of atypical? So the smears are usually highly cellular with increased dispersal of single intact cells. There is enlargement and pleomorphism of the nuclei. There is presence of necrosis or mucin, and some complex micropapillary or cribriform architecture of epithelial tissue fragments. The specific cytological features that are considered atypical should always be stated. The diagnosis, if possible, should include the differential diagnosis and the diagnosis considered most likely. For example, usual epithelial hyperplasia or a papillary lesion. So what are the three major causes of atypical? So first would be the skill of the operator. Poor FNAB technique may result in low cellularity and obscuring blood or ultrasound gel. Overly forceful smearing will cause crush artifact and dispersals of cells. Poor handling of material will result in air drying artifacts. All of this will result in suboptimal smear, making interpretation difficult. Secondly, interpretative problems to occur, and these are due to overlapping cytological features between proliferative breast lesions, such as usual epithelial hyperplasia, intraductal papillomas and fibroadenomas, and low-grade in situ lesions and low-grade invasive carcinomas. Thirdly, the degree of training, experience, and ongoing caseload and expertise of cytopathologists in interpreting the material impact on atypical rates. Less experienced pathologists may focus on dispersal or nuclear atypia and ignore the overall diagnostic features of the lesions, and these are most typically encountered in fibroadenomas involved by your usual epithelial hyperplasia. So what are the common lesions associated with atypical? So these are usually proliferative types of lesions. So these are your fibrocystic change by itself or in association with usual hyperplasia, fibroadenoma with associated prominent epithelial proliferation, a fibroadenoma with a cellular stroma, radial scars, proliferative lesions like your columnar cell change, flat epithelial atypia and sclerosing adenosis, intraductal papillomas with epithelial hyperplasias, adenomyepithelioma, spindle cell lesions like it's a toss-up between a cellular fibroadenoma versus a benign phylloides tumor. Lobular neoplasia will also yield an atypical result because of the low cellularity. Low-grade DCIS and low-grade invasive carcinomas are some of the lesions that may fall under atypical category. Let's look at some example. So this first case here is atypical, and what made it atypical is that number one, this is a highly cellular smear, and number two, we see a lot of these singly scattered intact epithelial cells in the background, and there is overlapping and crowding of the nuclei with some nuclear enlargement in this group compared to the other groups. But one has to take note that we still see a lot of myepithelial cells in the background as well as within tissue clusters. So we see a lot of our myepithelial cells here. So this is considered as atypical. So histological follow-up showed that this came from a fibroadenoma with florid epithelial hyperplasia. This next case here came from a patient who underwent radiotherapy, achieving complete pathological response. A repeat FNAB on follow-up was done, and here we see that there are nuclear enlargement. And if we compare this nuclear, they are moderately enlarged compared to one here, which are smaller in sizes. There is prominence of the nucleoli, and there is crowding of the nuclei. But would take note that the NC ratio is still good, nuclear contour is smooth, and the spaces are not rigid, so they are still slit-like, and we see interspersed myepithelial cells within these tissue fragments. So this is considered as atypical. Another case here. So we see contrast of two types of cells or two population of cells. This one are your usual benign ductal epithelial cells, while this group here, you would note that the cells here are enlarged compared to this group here. They are overlapping and crowded with few singly scattered cells in the background. But still, we have a lot of our myepithelial cells. See our naked bipolar cells in the background, and within these tissue fragments, we still see myepithelial cells here. So histologic follow-up showed this one to be that of a papilloma with usual epithelial hyperplasia. So this case here came from the case of my friend, Dr. Jamidi. So this was a aspirate of a papillary lesions. We see a large cohesive flat sheet of our epithelial cells here with a lot of interspersed myepithelial cells. But beside this group, we see this other group that are showing more darker nuclei and large and crowded overlapping nuclei. But still, these fragments are, or this group are cohesive with myepithelial cells in the background. Histologic follow-up showed an introductory papilloma with florid epithelial hyperplasia. So this is another example of a typical case. We see the difference of the two populations of cells here. So this group here are smaller while these groups are bigger. So they are more crowded but still cohesive. Most of them are cohesive with few that are singly scattered here in the background. So this turned out to be a intraductal papilloma with atypical ductal hyperplasia. This smear here shows abundant mucin in the background with few of these loose clusters of epithelial cells. So this was called atypical because only a few number of epithelial cells were seen. Majority of the smear showed mucin. So if there are adequate number of epithelial cells, one needs to search for presence or absence of your myepithelial cells. Okay. So this lesion here turned out to be a mucocil-like lesion. Next on this slide, we see a cribriform-like architecture. You would see that these cells, the circles here are rigid. Here, they are more rigid than compared to the slit-like spaces that we've seen earlier. But we see that the cells surrounding these spaces show some of these myepithelial cells still. So this, if you only see a few of these on the smear, this is considered atypical. This slide shows a cohesive group of benign epithelial cells here, but associated with this hypercellular stromal fragment. So we're not sure whether we are dealing with a cellular fibroadenoma or a benign phylloides tumor. So it is most plausible to call this as your atypical, and a biopsy can be done. So what is the management for atypical cases? So repeat fine needle aspiration biopsy is recommended if the atypical diagnosis is considered primarily due to a technical problem. When there is sufficient quality material for interpretation, the triple test should be applied. If either or both the clinical and imaging findings are indeterminate or suspicious, a repeat fine needle aspiration biopsy, or commonly a core needle biopsy, is mandatory. In low to middle income countries, if repeat fine needle aspiration biopsy still shows a typical result, an excisional biopsy should be recommended. The next category, the fourth category. So what are the causes of suspicious of malignancy? Causes are similar to those of the atypical category, which includes technical problems related to the skill of the operator doing the FNA, making smears and handling the material, experience of the interpreting cytopathologist, and the nature of the breast lesion. One has to take note that the cytological features of proliferative lesions and low-grade or in situ carcinomas overlap, and great care should be taken in assessing smear pattern and nuclear atypia. So the problem here likewise mirrors the difficulties encountered in surgical pathology in distinguishing atypical proliferative lesions from low-grade ductal carcinoma in situ. So recognition of these features prevent undercalling low-grade ductal carcinoma in situ as a proliferative lesion and overcalling low-grade ductal carcinoma in situ as invasive carcinoma. So these are the characteristics of a low-grade ductal carcinoma in situ. So in low-grade lesions, the smears are usually highly cellular. We'd see patterns of large tissue fragments showing cribriform, micropapillary or papillary architecture. There is a variable but often marked increase in dispersed single cells showing mild to moderate nuclear atypia. There is a greatly reduced number or total lack of myoepithelial cells associated with epithelial tissue fragments, and there is scant or absent bare bipolar nuclei in the background. How about for high-grade DCIS? So high-grade ductal carcinoma in situ is associated with extensive necrosis and calcifications. One would see high-grade nuclear atypia in dispersed single epithelial cells and both small and larger crowded epithelial tissue fragments. And what if this is a low cellularity smears but show high-grade nuclear atypia, this would fall under suspicious of malignancy. Another one that would fall under suspicious of malignancy is if we see a highly dispersed pattern of large atypical cells suspicious for lymphoma. Here we see a highly cellular smear, and we see these epithelial cells here that are crowded and overlapping each other. In the background, we see a lot of necrotic material. So this is another picture of the same patient. So in this fragment, we see this large, huge sheet forming these rigid spaces here, similar to a cribriform pattern, as well as these micropapillary projections. So this is a micropapillary projections. We would see that this has a narrow base, a bulbous surface or bulbous point with a narrow neck here, and this is a micropapillary architecture. We see that the cells here are composed of these monotonous looking cells, but they are small. In that crowded area, we see this crowded, more atypical looking cells that are hyperchromatic, and we see some of these more smaller monotonous looking cells that are scattered in the background. We see more of the monotonous looking cells in the background here, and we do not find any myoepithelial cells interspersed in any of these fragments. So this is another case from a different patient. So here the smear still shows hypercellularity, and in these fragments we now see monotony of these atypical looking cells. So the cells are hyperchromatic, and we do not find any myoepithelial cells interspersed within these fragments or scattered in the background. And if we look at the background, we see some these atypical cells, the same atypical cells we find in tissue fragments scattered in the background. So this is suspicious of malignancy features. Another picture from the same patient. See here the nuclear enlargement and hyperchromasia of these cells. Look at the monotony of these cells. We do not find any myoepithelial cells in fragments as well as in the background. So these are features suspicious of a low-grade ductal carcinoma. Here, we see nuclear enlargement, crowding, no myoepithelial cells within fragments, and some scattered cells in the background with no naked bipolar cells in the background. So again, features suspicious of malignancy. In this smear, we see this is a sparsely cellular smear on low cellularity smears, but we see these large epithelial fragments trying to form cribriform architecture here. And interspersed within these cells will be these larger, more atypical looking cells that are not associated with any myoepithelial cells, and some of the cells are scattered in the background here. And this cell shows moderate to marked nuclear atypia. In other parts of the smear, we see this cribriform pattern with this micropapillary pattern as well. And in closer view, we see the rigid spaces here that are the punch-out spaces we see in cribriform architecture, and the cells composing this epithelial fragment show nuclear monotony and hyperchromasia. So this smear is suspicious of a low-grade ductal carcinoma. Can be a ductal carcinoma in situ. This is from another patient. So this is a sparsely or low cellularity smear as well. And we find this epithelial fragments here, but the compositions of this epithelial fragment shows marked atypical nuclei that are crowded and overlapping. So some of these cells here are attempting to split away from the group. So this is suspicious of malignancy category. And here we see more crowding of the cells overlapping. The cells are hyperchromatic with irregular nuclear contour here. So this is suspicious of malignancy. We do not see any myoepithelial cells in this tissue fragment. So what is the management for suspicious of malignancy cases? So if this is diagnosed, it should lead to a review of the imaging findings, and further biopsy is an absolute requirement, which is most commonly a core needle biopsy. However, in low resource setting, if no core needle biopsy is available, then a surgical excision biopsy is required before specific treatment is recommended. When the suspicious of malignancy diagnosis is made at ROSE, it should prompt immediate core needle biopsy. The last category is malignant. So malignant is defined as follows. A malignant cytological diagnosis is an unequivocal statement that the material is malignant, and the type of malignancy identified should be stated whenever possible. The incidence of this category is varied. It starts from low, 5.54, to as high as 21%, depending on the institutions. In tertiary institutions and well-equipped institutions, the incidence of malignancy in FNA is low because on radiograph, if the findings is suspicious of a malignancy, they would proceed more to do a core needle biopsy rather than an aspirate. While in low resource settings, it is higher because a lot of these patients would undergo fine needle aspiration as an initial assessment. So the risk of malignancy range is high. So it ranged from 99 to 100%. Okay, so almost 100%. The positive predictive value is likewise high, approaching 100%. What are the key cytologic findings in malignant? So these are the key cytologic findings listed here. So we see high cellularity smears with prominent dispersal of single cells. There's crowded tissue fragments with overlapping nuclei. We see nuclear enlargement and marked anisonucleosis. There is pleomorphism of nuclear margin, nuclear size and chromatin, hyperchromasia, prominent nucleoli, And these last four features listed down here are features suggestive of invasive carcinoma. And these are your tubular architecture of your epithelial fragments, presence of intracytoplasmic lumina in atypical epithelial cells, elastoid fragments, and stromal fragments infiltrated by carcinoma. So the malignant diagnosis should only be used when there is a full constellation of cytological findings and no discrepant features is seen. So it is recommended that the type of malignancy should be mentioned or at least suggested in the report. And what are these common malignant lesions encountered under the malignant category? The four most common would be the following: your invasive breast carcinoma, no special type, or the ductal carcinoma, lobular carcinoma, mucinous carcinoma, and tubular carcinoma. Some of the less commonly encountered lesions are the ones listed on the other side. So we do not have any problems calling something as outright malignant. So we see a lot of these cases. So in here, it is a fairly cellular smear, and we see that these cells are in loose clusters, and most of them are scattered singly. On higher magnification, these cells are large. If you compare them to inflammatory cells here, these cells here showed marked pleomorphism of the nuclei, and crowded here, some of the nuclei are irregular in shape, they are hyperchromatic, and we see a lot of overlapping of cells. And in this cluster here, we do not see any myoepithelial cells. And same atypical cells that we see in the clusters are seen scattered singly in the background. Another picture of those cells. See the crowding of these cells and the pleomorphism of these cells, the nuclear irregularity of some of these cells. So this is no doubt malignant features. For this case here, we see a lot of the singly dispersed cells in the background. We do not see any cohesive clusters. Some of these one are in loose clusters only. We do not see any myoepithelial cells in the background. We see some stromal fragments here infiltrated by your atypical cells. And on closer magnification, these cells showed moderate nuclear atypia. Okay, so note no myoepithelial cells in the background and within tissue fragments. So this is feature of malignancy. And this is the last example here, which shows undoubtedly a malignant features. Look at the marked pleomorphism of these cells. Look at the nucleoli of these cells and the nuclear irregularity and hyperchromasia. See a lot of these same atypical looking cells scattered in the background. So this is undoubtedly malignant. So what is the management for malignant lesions? So a malignant FNAB cytology diagnosis should be correlated with the clinical and imaging findings. And if the triple test is concordant and the material is available in the cell block for prognostic and treatment markers, definitive therapy, including neoadjuvant chemotherapy and surgery, can be commenced. If the fine needle aspiration biopsy cytology diagnosis does not correlate with the other components of the triple test, core needle biopsy is mandatory. And if a core needle biopsy is not available, an excision biopsy is needed. So now for breast fine needle aspiration biopsy, if there is adequate material, we can do cell block preparations. And on cell block preparations, we can do these ancillary tests as follows. So we can either do immunohistochemical studies as well as molecular studies on these materials. Is there improvement with the use of the system? So we conducted this study and we found that there is improvement with the use of the Yokohama system definition for each category. when we compared it to the original diagnosis, there was marked improvement in categorization of cases. So there were fewer malignant cases that were called as benign, and there was no benign case that was called malignant. So if we look at the specificity and sensitivity, the positive predictive value and the negative predictive value increased with the use of the system. This is from another study wherein Dr. Leifeld and company looked at the effect of pathologist experience. So here it showed that there was overall agreement between 4 pathologists. So the weighted agreement was around 91.91, which is considered as almost perfect agreement. And when they look at the difference between each pathologist's experiences, they note that there is more agreement between pathologists with more experience compared than those pathologists with less experience. So we did a study on the effect of cytopathologist experience on using the system. So we have 2 colleagues who have 1 year experience on breast FNAB diagnosis and 2 colleagues with 5 years experience in breast diagnosis, and we compared this to an expert. So we found that the categorization based on the system by pathologists with little and intermediate experiences showed no significant differences in diagnostic accuracy, indicating that the standardization undoubtedly improves the fine needle aspiration biopsy diagnosis. Nevertheless, we found that pathologists with little experience showed a lower concordance rate with the expert pathologists compared to those with intermediate experience, which showed an almost perfect agreement with the expert pathologist. If we look at here, those with less experience tend to miscategorize atypical lesions into benign category. And most of these lesions were found to be proliferative lesions on follow-up. Although there are specific cytological criteria or scenarios for issuing a diagnosis of atypia, some may be quantitative and misinterpreted in and out of context by the inexperienced. It has been shown that increasing experience of aspirators and pathologists leads to a more consistent proportion of cases being classified as atypical or suspicious. Assessment of sufficiency was similar across pathologists of different levels of experiences. So specific training and continuing exposure to a significant caseload may still be required for a more consistent and reproducible fine needle aspiration biopsy diagnosis. And now, in the time of COVID, so fine needle aspiration biopsy is a fast and safe alternative to needle core biopsy. Although a cytopathologist following the Yokohama system can definitely tell apart high-grade ductal carcinoma in situ from an invasive carcinoma, they should be able to differentiate these lesions from low-grade ductal in situ carcinomas and other low-risk proliferative lesions of the breast. Clinical management of high-grade ductal carcinoma in situ is very similar to the management of invasive carcinoma, so allowing diagnosis and surgical management without core biopsy. When a diagnosis of low-grade ductal carcinoma in situ is made, either in the atypical or suspicious categories, a biopsy may be necessary. However, a recent series from an Italian reference center has shown that when performed by experienced cytopathologists following the Yokohama system, the majority of diagnoses are either benign or malignant. The lack of a definitive diagnosis and poor interobserver reproducibility have been addressed by the Yokohama system. Furthermore, they have been shown to be able to provide adequate material for ancillary testing. And in the time of COVID-19 now, Extraordinary times require extraordinary measures. Thank you for your attention. If you have any questions, you may type them in the chat box and we'll be happy to answer your questions. Good morning, everyone.